Welcome to this Pearl of Laboratory Medicine brought to you by AACC and the Clinical Chemistry Trainee Council. View this and many more pearls as well as other free educational material at traineecouncil.org.
Hello, my name is Nahla Heikal. I am an assistant professor of clinical pathology, University of Utah, and a medical director for thrombosis, hemostasis, and immunology flow cytometry at ARUP Laboratory. Welcome to this Pearl of Laboratory Medicine on Thrombotic Thrombocytopenic Purpura and clinical importance of ADAMTS13 assays. Thrombotic Thrombocytopenic Purpura, or TTP, is a rare, potentially fatal, and diffuse disorder resulting from occlusion of small arterioles and capillaries by microthrombi. It is classically defined by the pentad of microangiopathic hemolytic anemia, severe thrombocytopenia, neurologic abnormalities, which can be focal or in the form of seizures, stroke, coma, confusion, or headache. Renal function impairment in the form of microhematuria, hemoglobinuria, proteinuria, and casts, with absence of renal failure in most cases, and fever. TTP patients may not present with the full pentad, and presentation may be variable, which led to recent streamlined criteria to include microangiopathic hemolytic anemia and thrombocytopenia with no clinically apparent alternative explanation for thrombocytopenia and anemia. This streamlined criteria help guiding the initiation of plasma exchange. TTP may involve many organs, including adrenals, heart, kidney, brain, and pancreas. Most cases are acquired idiopathic autoimmune conditions, but TTP can also be congenital, the Upsher-Shulman syndrome. TTP is one of the differential diagnoses of disorders characterized by thrombotic microangiopathy, which is a broad pathophysiologic process that leads to microangiopathic hemolytic anemia and thrombocytopenia, and involves capillary and small vessel platelet aggregation with organ damage. Differential diagnoses include DIC, hemolytic uremic syndrome, either diarrhea positive or negative, disseminated malignancy, autoimmune diseases, drugs like kinin, interferon, calcineurin inhibitors, and simvastatin, malignant hypertension, pregnancy associated with HELLP syndrome, and infections, which can be either viral, like CMV infections, adenovirus, herpes simplex, bacterial like meningococcus and pneumococcus, and fungal infections. The pathophysiology of TTP is attributed to the accumulation of ultra-large von Willebrand factor multimers that bind more avidly to platelet glycoprotein 1b, causing platelet adhesion and aggregation that leads to microvascular occlusion. The ADAMTS13 normally cleaves and processes the ultra-large von Willebrand factor into smaller fragments. In individuals with severe deficiency of ADAMTS13, identified as being less than 5 to 10%, the accumulation of the ultra-large von Willebrand factor multimers leads to platelet adhesion, aggregation, and microvascular thrombosis. In TTP, severe ADAMTS13 deficiency can be acquired due to the formation of autoantibodies or congenital due to mutation in ADAMTS13 gene. TTP is also called ADAMTS13 deficiency-mediated thrombo-microangiopathic anemia. It is important to realize that mild deficiency of ADAMTS13, more than 10%, is identified in uremia, sepsis, chronic inflammation, DIC, pregnancy, post-operatively, and liver disease. Rarely, severe ADAMTS13 deficiency, less than 10%, has been identified in liver disease and cirrhosis, severe sepsis, sepsis-induced DIC, and disseminated malignancy. Laboratory testing to perform in the evaluation of TTP include review of complete blood count that shows normocytic anemia, profound thrombocytopenia, with platelet count frequently less than 20, and often increased reticulocyte count, red cell distribution width, and mean platelet volume, which is an indication of the increased turnover of red blood cells and platelets. Morphologic evaluation of peripheral smear shows erythrocyte polychromasia and idocytosis with schistocytes. And although schistocytes are a hallmark for TTP, they are not specific and can be found in other thrombotic microangiopathy. Features of hemolytic anemia include decreased hemoglobin, increased lactate dehydrogenase, and negative Coombs test since the hemolysis is intravascular and not immune-mediated. Features of renal dysfunction with elevated creatinine, proteinuria, and hemoglobinuria. Also, cardiac dysfunction may be detected with elevated troponin T. This slide shows peripheral blood smear for patients with TTP showing severe thrombocytopenia and schistocytes indicated in the picture by the arrows. Schistocytes are fragmented erythrocytes formed by the microvascular thrombi. The diagnosis of TTP has changed from clinical diagnosis of exclusion to pathophysiologic diagnosis based on ADAMTS13 laboratory results, which include ADAMTS13 activity, antigen, Bethesda inhibitor titer for the detection of neutralizing antibodies, and autoantibody titer for the detection of non-neutralizing antibodies. Activity or antigen test. The activity tests measure the amount of functional protein. It is low in both qualitative and quantitative abnormalities. A result with severe deficiency supports the diagnosis for TTP. ADAMTS13 activity at the diagnosis is associated with response to plasma exchange, so patients with severe deficiency are more likely to respond. The activity level is also related to the frequency of relapse, so patients with severe deficiency are more likely to relapse, and severe deficiency during clinical remission means relapse is more likely. ADAMTS13 activity is also associated with overall survival. Patients with severe ADAMTS13 deficiency have better overall survival than patients without severe deficiency due to the better response to plasma exchange. The antigen test measures the amount of protein, but not the protein function, which makes the antigen test less sensitive for the diagnosis of TTP because it cannot detect qualitative defects and therefore not usually performed. A commonly used method for the activity assay is the fluorescence resonance energy transfer, or FRET. The assay uses a synthetic von Willebrand factor peptide that contains the ADAMTS13 cleavage site. It contains fluorescent tag and a quencher that suppresses fluorescent emission. The active ADAMTS13 from patient plasma cleaves the peptide bond, separating the quencher from the fluorescent tag, and then fluorescence is quantified by a fluorimeter. ELISA is another commonly used method for ADAMTS13 activity. It uses recombinant von Willebrand factor peptide containing the ADAMTS13 cleavage site captured to a microtiter wells. ADAMTS13 in patient sample cleaves the von Willebrand factor fragment, exposing a specific amino acid sequence which can be detected by labeled detection antibody, and color develops using the horseradish peroxidase reaction. Detection of ADAMTS13 antibodies is important to differentiate acquired from inherited TTP, since no autoantibodies are detected in inherited TTP. The presence of autoantibodies supports the diagnosis of acquired TTP, and its presence at diagnosis is associated with higher risk of relapse, and persistence in clinical remission is associated with higher risk of relapse. It has also been shown that high titers are associated with delayed response to plasma exchange, refractory disease, and early death. It is important to note that it has been reported that about 4% of healthy individuals and 13% of patients with systemic lupus erythematosus have autoantibodies to ADAMTS13 in the same range observed in TTP patients, despite having normal levels of ADAMTS. The autoantibodies for ADAMTS13 come in two types: the neutralizing antibodies, which are more common, about 2/3 of cases, inhibit ADAMTS13 function and often called ADAMTS13 inhibitor and detected by the Bethesda assay. The non-neutralizing antibodies are less common, 1/3 of cases. They bind to ADAMTS13 and accelerate clearance and often called ADAMTS13 antibody and detected by ELISA. This slide illustrates the Bethesda assay for the detection of ADAMTS13 inhibitor. It is technically difficult lab-developed test that evaluates residual ADAMTS13 activity in a 1-to-1 mixture of patient plasma and normal pooled plasma after incubation for 2 hours at 37 degrees centigrade. Inhibitory antibodies present in the patient plasma inhibit ADAMTS13 activity in the pooled normal plasma. A controlled mixture of normal pooled plasma and buffer simulates absence of an inhibitor, is also incubated for 2 hours, and the residual ADAMTS13 activity in the patient mixture is compared to the residual activity in the control mixture. If an inhibitor is present, the recovery of ADAMTS13 activity in the patient mixture is lower than expected. A 1 Bethesda unit is defined as the amount of inhibitor that decreases residual normal pooled plasma ADAMTS13 activity to 50% of the expected value. The non-neutralizing autoantibodies directed against ADAMTS13 can be measured in serum or plasma samples by sandwich ELISA. A full-length recombinant ADAMTS13 is immobilized on the surface of an ELISA plate and binds to anti-ADAMTS13 antibodies from the patient sample. Bound antibodies are detected by a labeled secondary antibody that participates in a chromogenic reaction. The ELISA test for the detection of non-neutralizing antibody is highly sensitive for idiopathic TTP, but less specific than the Bethesda assay. This is a suggested algorithm for the diagnosis of typical TTP cases. Start by ADAMTS13 activity test for patients with clinical suspicion of TTP. Normal results can exclude TTP and consider other thrombotic microangiopathy. Mild to moderate results, more than 10%, are unlikely suggestive of idiopathic TTP, but with strong clinical suspicion, the inhibitor assay, the Bethesda, may be indicated. If ADAMTS13 activity is markedly decreased, less than 10%, the inhibitor assay, the Bethesda, is recommended. Detected inhibitor confirms the diagnosis of acquired TTP with neutralizing antibodies. But if inhibitor antibody is not detected, the autoantibody ELISA test is indicated. If it is detected in high titer, the diagnosis of acquired TTP with non-neutralizing antibodies is confirmed. If it is detected in low titer, clinical correlation is required. If non-neutralizing antibodies are not detected, this is maybe inherited TTP, and sequencing of ADAMTS13 gene should be considered. If sequencing is positive, the diagnosis of inherited TTP is confirmed, and if it is not, this needs clinical correlation. Hereditary TTP, or the Usher-Shulman syndrome, is rare. About 5% of TTP cases occurs in infancy or childhood and may recur as chronic relapsing TTP. Symptomatic onset of about half of hereditary TTP is before the age of 5, with the remainder presenting later, usually after the age of 20. The classic hallmarks are neonatal jaundice with negative Coombs test requiring blood transfusion. It is differentiated from other causes of thrombocytopenia by ADAMTS13 activity test less than 5%. No autoantibody detected to ADAMTS13 in inherited TTP. The inherited TTP is autosomal recessive, compound heterozygous or homozygous. Carriers have about 50% of normal activity and are asymptomatic. ADAMTS13 gene is located on the long arm of chromosome 9 and has 29 exons, and at least 76 mutations have been described. Mutations have been found throughout the gene. Genetic testing has more than 99% analytical sensitivity and is useful to differentiate from acquired TTP, evaluate potentially affected family members including prenatal diagnosis, and can also establish genotype-phenotype correlation. So now we'll move to the prognosis and treatment of acquired TTP. The untreated TTP is associated with high mortality due to multi-organ failure. Although majority of patients now survive the initial episode, relapse is seen in 30 to 60% of patients, more frequently in the first month. Treatment must be initiated before results of lab testing are available, with early initiation of plasma exchange with fresh frozen plasma, which is subjected to be continued for a minimum of 2 days after complete clinical remission that is identified by normal platelet count, normal LDH, and resolution of neurologic symptoms. Other treatments for resistant cases include the off-label use of immune suppressive and immune modulatory drugs like steroids, rituximab, cyclophosphamide, cyclosporin A, or vincristine. New treatments are also being evaluated, including N-acetylcysteine, bortezomib, recombinant ADAMTS, and cabtazizumab. Thank you for joining me on this Pearl of Laboratory Medicine on Thrombotic Thrombocytopenic Purpura and clinical importance of ADAMTS assays.
For more like this, as well as articles, podcasts, and more, please visit the Trainee Council at traineecouncil.org.